So BCL2 inhibition has really been demonstrated to be one of the more effective treatments for hematological malignancies that has emerged over the last decade. The challenge with the current BCL2 inhibitor that we have, venetoclax, is that many patients either don't respond or respond initially and then relapse. And so there is a need for better BCL2 inhibitors that do the job but overcome some of the problems that we see with venetoclax. And there are a number of emerging BCL2 inhibitors. There are inhibitors of BCL2 alone, and then there are inhibitors of both BCL2 and BCL-XL. And when we're thinking about this class of drugs, we want drugs that work for more diseases than venetoclax does, but have less toxicity, that do not cause tumor lysis syndrome, that can be given as an oral tablet, can be given without the palaver of venetoclax dose escalation, and are easy for patients to take, so one tablet a day. We have in the emerging BCL2 selective inhibitors, we have drugs such as lisinopril, it's always hard to pronounce, which has demonstrated some early efficacy in a number of hematological malignancies, as well as sonrotoclax, which is made by BeiGene. There are a number of others that are earlier in their development. In the BCL-XL, BCL2 co-inhibiting agents, we have drugs such as navitoclax, which is an earlier BCL2 inhibitor that has been resurrected. That drug is complicated by on-target thrombocytopenia, and so dosing needs to be done with care. And also a drug called AZD 0466, which is given as an IV agent once a week. So there are a number of emerging drugs. They all have pros and cons. How they compare to venetoclax really is yet to be seen.